Welcome. So I'm Valerie Wolf. I realize that my identity is one of many OHCOW moderator / co-hosts, so it's hard to tell who's who. So I'm the Executive Director of the South Central Region for the Occupational Health Clinics for Ontario Workers, more commonly known as OHCOW. And we do want to welcome you today to our 5th annual May Day celebration maybe isn't the right word, but it's our May Day event in which we mark May Day itself, which is the International Workers' Day that's recognized around the world, and of course not just a play on words, the literal words May Day, which is an internationally recognized cry for help. And for many years we have recognized that the stress involved with work and what we consider to be workplace mental health, which is the impact on individual and collective mental health by the organizational factors and other workplace factors, has a major impact on people's lives and on their health, and never more so than now. I was reflecting this morning that last year was our first step for the whole organization, actually, in doing such an event on a virtual basis. And we expanded from a one-day event into a 5-week event, which allowed us to bring many more speakers from around the world to our Ontario audience, and also to increase our audience to people from around the world. So it's been a very enriching experience. And I was also reflecting that we started last year's series, of course, in the beginning of the pandemic, during what at that time we thought was a battle, and now we know it's a war. So, and we feel that we've been at war, I think, for more than a year. So it's we started with pandemic experience, and we're starting again this year with pandemic experience, and the impact that it's had and continues to have, and will likely have for a long time in the future. So without further ado, I'd like to introduce our first speaker. So the agenda is showing on the screen right now, that we're going to start with some colleagues, partners from Turkey, to hear about the qualitative analysis of psychosocial risks among nurses during COVID-19. And then we're going to switch to some content from Canada with three surveys and recent and past results from those surveys. And then we're going to, at the end, have a panel among all the speakers and the rest of us about what does this mean for prevention? What do these results show that we can make a difference even during this time of war, as I said before. So I will introduce now Burcu. So Burcu Guler is a professor at IKCU. I'm sure I will not pronounce it properly, but the Izmir Khatip Çelebi University Psychology Department, studying at the Division of Industrial Organizational Psychology. Her research interests include occupational health psychology, positive psychology at work, and human resources management.
Thank you, Valerie. Hi, everyone. I know it's very difficult to pronounce our university's name, and also maybe my name is hard to pronounce. I am Burcu, and we did this research with Yücel and Buket from Dokuz Eylul University. First of all, I would like to thank you that you're having us here, having an opportunity to present our research here. Our research is actually during COVID-19. We thought that the healthcare workers are in a real struggle with this issue. And we tried to make a qualitative analysis, and especially nurses were the volunteers for this research. We did this research at a university hospital, and the field study of the research was supported by our Turkish, the Scientific and Technological Research Council of Turkey. And here are the details of our, sorry, but I'm seeing, I cannot see my screen. Yes, now that's okay. Why we did this research, when we look at the aim of the study, we tried to explore how they perceive their psychological environment and the psychosocial risks the healthcare workers, how do they perceive, and what are they experiencing during COVID-19. And since March 2020, we have been in this process. So we wanted to examine the organizational context and practices they experience, especially for the healthcare staff. But as I said before, nurses were much more volunteers than the other healthcare staff. And at the end of the study, first we started we wanted to make an intervention, organizational and also psychological intervention for the healthcare workers. And but in order to make this interventions, first we thought that we should understand in what kind of an environment they are and how they perceive their environment and how they perceive their work. And in order to offer solutions and organizational and psychological intervention methods, or what should be solved in the process, we wanted to look at and we wanted to hear their voices, actually. So first I want to introduce the sample of our study and then the procedure of our study. During, I think, 2 or 3 months, we did interviews, and totally 17 nurses agreed to participate in the study, and just one of them was men, and all of them were infected during the study. We thought that it would be better to make an interview while they are sick and they are at the quarantine at their home, and they were invited to interview and they are in quarantine, and we did the phone calls. I will explain them later in the procedure section of our study. The ages are nurses, but also there are some younger nurses who recently graduated from nursing schools, and all of them are undergraduate. Their education is undergraduate, and just one of them is master's degree, have a master's degree. Married and single ones are nearly equal, and many of them have children. So this was really a very important problem while doing their work during COVID-19. And the experienced nurses are high in number also. Maybe our departmental categories are different than Canada or other countries, but we also have a COVID intensive care unit was also established, and many of the nurses have worked there. Emergency department, pediatric, hematology, hospital infection. You see the departments here. And this is called COVID-19 service work, also established during this process. And some of the nurses have been appointed to work within these services. many of them, nearly half of them, worked in this department, newly established department. While we were doing this research, we tried to base on COPSOC, and COPSOC questions were analyzed, and the dimensions which are included in COPSOC, within COPSOC, were included in our interview questions. For example, we asked about what's your responsibility at work, and we want the nurses to define the responsibility, all of these questions, before COVID also, and compare before and after COVID-19. And we asked the responsibility at work and safety and health issues at work also. What do they think about safety and health issues during those times? What's your social environment at work also? We meant social relationships between peers, leaders, and other beneficiaries, patients, and their relatives also. We asked especially the home-work imbalance or interface while they are working. Also, union and associations support, the occupational associations support also. Do they think that, do they perceive a real support from these organizations, other organizations? And what were the issues affecting their psychological well-being? Strengths and resources also protecting their psychological well-being. And we also asked suggestions for improvement of working conditions to the nurses. And our procedure was that nurses who were infected were contacted via Workers' Health Department of the hospital. This was a university hospital, and at Izmir. During this call, the Workers' Health Department asked whether they want to be included in a qualitative study. And if they say yes, mostly the nurses have said yes. The appointments are arranged, and they were recorded on Excel sheet and shared on Drive. This was a collaborative work. Our secretaries also take these appointments, and just one man and 16 women nurses agreed to be volunteers for the interviews. Online voice calls were made. Just one group interview was there, and 16 individual calls made, and each session was held approximately 40 minutes or something. Informed consent was taken, and participants agreed also for voice recording. And these recordings transcribed to Word documents, and analysis were made with MaxQDA program, qualitative analysis software. And Yücel and I developed codes and themes. We are the experts here in this field. So we made our codes and arrived to the themes also. This was an example of Excel sheet, which we share on the Drive. All this stuff was done here, and if also the communication numbers are taken from the management of nurses within the hospital. So what are the findings of our study? I will present some codes and themes here. We have been also reading the transcriptions in detail, and also arrived such codes and themes. And we thought that there are some new problems emerging with COVID-19. which are especially risk of infection is a very greatly emphasized quote here. And the nurses are afraid of infection from outside. Outside infection is also seen very important, and infection within the hospital also. Increase problems. Detailed stuff here about violence, workplace violence, and they are also worrying about not to be able to socialize because of distance, and there's a fear of working at COVID-19 service, which I emphasized before, the newly established services here, departments here. So these are the new problems emerging with COVID-19. And when we look at the demands, we also categorize these according to OHCOW. And we saw that psychosocial risks about work environment and about the work itself differ. And about the environment, we see that there is a high injustice at work, high ambiguity, chaos, and disarrangement, unfortunately, and lack of staff, insufficient number of personnel, unfortunately, was a real problem here, and physical problems were also defined by the nurses. Within injustice at work, the nurses have financial problems, really have financial problems. They don't think that they are getting what they deserve. So we see that there is a high effort-reward imbalance, unfortunately. And while doing this, they compare themselves with other workers, with, for example, teachers also, with other service workers. And some of them are claiming about job unfit. And in the Ministry of Health in Turkey, unfortunately, don't let them to take leave or to resign. And it's a really bad issue for them, and they perceive as an injustice. This makes them to feel injustice about work. Ambiguity, chaos, panic, and then adjustment. There are lots of department changes, and the last minute department changes, and different tasks and co-workers working with different tasks with co-workers are annoying them, crowded team, and no one to consult. For physical problems, really it's strange to say that, but catering services and problems of public transportation and short breaks are the issues about physical problems here. And for the quantitative demands, long working hours, new patients profile are worsening. Especially we did this research during, I guess, November, I guess, yes. And the COVID cases were increasing, and new patients profile are really worsening, they say so. And fatigue, health services nature, and increasing workload are the quantitative demands. And as emotional demands, negative emotional effect and condition of patients have psychological impact, unfortunately, on the nurses. They also see management problems, which include unsupportive leaders, and some of the middle management, especially, they are in between management and subordinates. They have struggles about this issue, and also they worry about having no empowerment from the leaders and perceived exclusion from the management side. And within management problems, we also see safety and health problems. For example, they are saying that the patient reception area is not a good place and is not enough because of high numbers, and difficulty of personal protective equipment usage. They are really hard to wear or use. And they see that, they perceive that the management is ignoring nurses' safety and health, and difficulty in, again, personal protective equipment control. First, they see a lack of PPE, but then this problem was solved. This violence issue, workplace violence, is an important issue. I don't know in other countries there are some instances or not, but they perceive that, unfortunately, we were expecting just the opposite, because the healthcare workers are very valuable and we also applaud them. But in the meantime, they can't take what they deserve, and from the public, from the management, from the patients also. And what they were faced with was workplace violence. And the reasons of violence about they are having very many problems about patients' relatives, and this was because of lack of empathy, and they refuse to wear masks, and they are having conflicts about this issue. Psychological reasons and negative reactions to healthcare workers to patients. Sometimes they are also they don't feel well, and they may have negative reactions to the patients also. And the most important problem here is maybe that there's a deficiency in security as a reason of violence. And what types of violence? Verbal, psychological, and physical violence they are facing with. This issue, homework, not just homework life conflict or interface, but also social life conflict. Social issue is added to this conflict because of negative feeling of lockdown and not socializing, and because of childcare problems, home workload, and since the workload is very high, there is an intolerance which is reflected to home, and this creates home, work, and also social life conflict. Not just homework, but also social life conflict. But also there are some protective resources here. Job resource is a job acting as a job resource, but this is home-related resources. That's why I want to show it here. And as home-related resources, emotional support from family and compatible work hours with spouse and supportive partners, social support are important issues here. As resources from emotional support from family, compatible work hours, resources, compatible workers. I think there's a confusion here. I'm skipping, yes. And when we ask what are the job characteristics, positive job characteristics influencing your job satisfaction, we see that the nurses are talking in two dimensions: intrinsic satisfaction, and also extrinsic satisfaction. But intrinsic satisfaction was emphasized much more than extrinsic, because just easy job finding is a kind of issue, positive job characteristic here. And as intrinsic satisfaction, liking the work itself and positive feedback from patients and helping, altruism, being experienced and mentoring others, challenging and active work are issues covered here. I think I'm running out of time. For other organizations, they are saying that labor unions are not with us, so they end their membership. And as suggestions, they say that we really deserve, we want to earn the deserved salary, flexible work hours, and improvement of physical conditions here. I'm skipping just to show you that, how many minutes do I have? I don't know, but the emotional exhaustion is really is related. This is a graph of graph of workplace violence and emotional exhaustion, and this is done on MaxQDA co-occurrence of codes here. And emotional exhaustion is mostly related with problems about patients' relatives, lack of empathy, patient-relative mask-wearing issue, and verbal abuse. They are all interconnected with each other. When we look at the individual outcomes and the demands issues here, again, co-occurrence of codes are presented here. For example, negative physical health is interrelated with department change, different tasks, and co-workers. Emotional exhaustion is interrelated with demotivated for being paid less than deserve, comparing with other workers, fatigue, and worry about infecting others. Anger management, anger at management, person, job unfit, they are interrelated. Pessimism, financial problems, long working hours are also interconnected with each other. And emotional exhaustion here, again, individual outcomes and management problems interrelation here. And emotional exhaustion, infection within the hospital, worry about infecting others, an infection from outside, self-blame and feel bad for being infected, again, interrelated with worry about infecting others. Stigmatization is a very important individual outcome here, feeling stigmatized from others, and increasing workplace violence is interrelated here. Anger at management, and also anger at management is perceived exclusion. They are related. I would show just the cross tabulations here, but I can say that according to the COVID-19 service working or not, for example, we see that infection within the hospital and also increasing workplace violence are perceived much more for the nurses who haven't worked at COVID-19 service. This implies that working at COVID-19 service protects individuals here, nurses here. So I'm skipping just the important ones. Maybe I can just say about conclusions and suggestions here. So here the results are the main results. There are emerging psychosocial risks during COVID-19. These are risk of infection, increasing level of harassment, maybe violence by patients' families, and lack of socialization due to social distancing. Risk of infection is seen to be related with, especially with the fear of contagion to others, and this creates really emotional demand on the individual nurses. And there are also other frequently emphasized job demands, which are staff shortage, lack of personnel, long working hours, together with increasing workload and fatigue, lack of justice, unfortunately. And this is due to perceived effort-reward imbalance. And PPE, personal protective equipment usage was found to be one of the most significant occupational health problems. The most emphasized organizational resource was found to be social support. And this social support is especially gathered from the peers, teams, and especially from the peers, but also team and leaders are supportive here. Despite adverse working conditions, the nurses are also found to be very intrinsically satisfied with positive feedback from the patients, opportunity to help others, and challenging conditions are really emphasized conditions, positive characteristics of work here. And nurses have struggled with financial deprivation, unfortunately, in Turkey, besides working in intimate contact with infected patients. So as a suggestion, we can say that the Ministry of Health, first of all, and the management should provide extra pay, salary increase, and financial support should be given to these nurses. And hospital management should provide psychological support and also training how to deal with the problems in order to prevent the chaos. Improve physical work environment should be improved, especially for catering, transportation, resting rooms, for personal hygiene. And with increasing workload, shifts should be arranged with reasonable work hours, and maybe flexible work schedules should be introduced, but empowering the individual workers especially. And about the workplace violence, this is important. Precautions should be taken for the relatives of the patients, and support should be taken from security staff. And communication between nurses and patients and the relatives should not be seen just the nurse's responsibility only. Staff who have dependents, this can be child and elder people, these should be supported because the married and having children are real burden while they are working. Since social support is a resource for decreasing burnout, we know that peer support groups and also leader support should be enhanced via meetings and trainings and work groups. Thank you very much.
There are no actual questions in the chat. I think we will shift to the next speaker, but it was very, very interesting, very resonating, I think, with the results that will be shared about Canada and a lot of the way that many of us feel, but also have seen in healthcare, and particularly again now with the third wave that's happening in Canada, that's higher than ever and putting more strain on the healthcare system. So this information about peer support, I think, is really critical. So thanks. So, and you're able to stay around to participate?
Yes, I'm here. Thank you.
Okay, thanks. Great, thanks. So now we'll switch gears. Thanks again for sharing the Turkish experience with us. I think it adds considerable dimension to our discussions this morning. So now we're going to talk about the Canadian perspective and pandemic experience survey results from healthcare, education, and worker survey results. And that's going to be presented first by John Oudyk, the occupational hygienist from the Hamilton Clinic, who has been working in workplace mental health as a pioneer for many years. And I was reflecting this morning that we got into looking at psychosocial risk factors as part of indoor air quality studies, and recognizing that impact that it has on perception of air and feeling and health at work. And we've come full circle, I think, because now indoor air quality is a whole different level of meaning when we're dealing with an airborne biological hazards. So anyways, here's John to share the overview, highlights, lessons, and implications from the survey, and then I'll introduce Peter and Leonor later. Thanks, John.
Thank you, Valerie. And that was very interesting, Burcu, because some of the themes that you came up with are also ones that we are going to talk about in our surveys. Just to describe the three presentations that will follow, I'll start off by talking about some of the descriptives and contexts of the surveys. Then Peter Smith will give the statistical analysis of it. And Leonor Cedillo will be talking about the qualitative analysis of some of the other comments that were at the end of the surveys. So the purpose of the survey was to try to capture the experience of workers while things were happening at the beginning of the pandemic. Later on, we continued the survey to capture the other waves. But it's hard to think back and remember how you felt last year at this time. So we want to catch it while it was happening. There were a lot of different people involved in the project. We started off with nurses' unions because healthcare workers were obviously on the front line and we were wanting to capture their experience. Later on, a number of us revised the survey to include non-healthcare workers. And last November and December, we worked with the teachers union, the ETFO, to adapt the non-healthcare survey for educators. So what the survey contains is we use some Copenhagen psychosocial questionnaire scales for burnout and sleep. We also used two scales that measure anxiety and depression. They're screening scales for clinical use. And then we also created our own measures of pandemic exposures and protective measures and training. Some of the COPSOC scales we used were quantitative demands, work pace, predictability, role conflict, supervisor support, and colleague support. And we created a similar one for family support. From our stress assess surveys, we used a rating of psychological health and safety climate and a question that asked about the organization's tolerance of behaviors that are harmful to mental health. For the third survey, we also elaborated the working at home questions, and we added some educator-specific questions. So for the educator survey, most of the people were working in class in face-to-face instruction, and they were working at the school or the work site for the whole week. Here I've broke down the education mode for the respondents, and there were just over 700 who were online and almost 5,000 who were in person. We asked the people who were working from home how satisfied they were, and about half of them said they were somewhat or very satisfied, but over a third were somewhat dissatisfied or very dissatisfied. So there was a clear split between the group on satisfaction from working from home. We asked about a dedicated workspace, and while 3/4 of them had a room to themselves or mostly to themselves, that means a quarter of the respondents, which is quite a few, had to either move from place to place or share or move around. Here are some evaluations of various equipment and workstation for working at home. And you can see there at the bottom that the two most problematic parts of the workstation at home were the desks and the chairs especially. Workstation comfort, again, about half of the people thought the workstation comfort was on the positive side, and just over a third were negative, and it was a similar split to the overall situation. We asked whether you experienced any new aches or pains while working from home or aggravated any previous ones, and almost 3/4 said definitely. And just for those who are also feeling similar problems, OHCOW has a couple items online that are available to help you set up your home workstation. We asked about internet connections, software, and tech support. And while the internet was reasonable, the largest failing was the tech support for the education staff themselves, or for the students or families that were receiving the education. We asked about how much money you had to spend to upgrade your working at home situation. And again, almost 3/4 had to spend more than $200. And then we had talked about communication between co-workers, between students and parents. Students and parents was very good. Communications with the school board were the least good. And then communications with coworkers and with supervisors were also not very good. And we asked about enough flexibility to meet your responsibilities of work and home together. And here you see two groups. You see a third of them who say it's a constant struggle, and the rest of them are a little more adapted to meeting the competing demands. And here you can see that over 1/4 of the people working from home have seriously considered leaving their job because of family issues. And 4% or 18 of them actually talked to their employer about the possibility of leaving their jobs. Then we asked, after the pandemic physical distancing restrictions are over, would you like to continue to work from home? And about 1/3 said no, they wanted to go back to the school. But another 20% or so said definitely they would like to continue working from home. Another 20% were unsure. And another just over 25% were part of the week. So it was really all over the map. There was no clear consensus as to whether they would like to. And then how much contact do you have with people at school? We're shifting gears now to the people that are working on site. And you can see that 1/3 of them had direct contact with students, the orange bars here, for interactions between co-workers, sharing entrances, lunchrooms, staff rooms, washrooms, locker rooms, etc., were the most common. But about 3/4 of them were at least within 6 feet or 2 meters within both students and co-workers. We asked, on a scale from 1 to 10, how would you feel? How would you rate your current level of fear about this whole pandemic situation, where 1 being little to no fear at all, and 10 being as much fear as I've ever felt? And the average for the whole group was 6.8. When we compared it to the healthcare survey and the non-healthcare surveys that we had done previously in April and May of 2020, these levels for the educators were higher. The healthcare was about a full point average higher than the non-healthcare. When we broke it down into in-person and online, they were slightly different, with in-person being more, having more fear, reporting more fear. Online, remember, some online workers were going to the school to deliver online services, so there would be other staff there. What's interesting to see for the online is that 10% were at the top, whereas only 8% for in-person. We asked, how concerned are you about bringing the virus home? And 41% were extremely concerned. The average score from 0 to 5 was 3.9. For healthcare, it was 3.8, and for non-healthcare, 2.9. So again, you can see educators being more concerned on average than healthcare. And again, splitting them up between in-person and online, the difference is a bit bigger, 42% being extremely concerned in person and 32% online. any infected people in your school work site. 36% had none. Just over half had one or more, but just over 10% did not know, which is interesting because the school data is available. However, it's very awkward to access. And we asked about COVID-19 experiences, and I'll focus on those who were tested. Of the whole group, 1,172 were tested for COVID, and 10 were positive. For it's a fairly low COVID test positivity. This was for on-site, and for online, the test positivity was actually almost twice as high, which is kind of curious. But it could mean that some of the people who were on-site moved to online once they tested positive. Our survey was done in November and December, and here you can see the number of staff cases of COVID related to schools over that time period. And you can see it was just rising at that time. And you can see after in April, the schools were shut down, but you can see how dramatically it rose. It's interesting, too, to look at those less than 20 school-age persons, which is the blue line, compared to the 40 and 50-year-olds. And you can see for the first wave in March, April, and May, they're much lower than the 40 and 50-year-olds. Over the summer, however, they were about the same. In the second wave, when we did our survey in this period, the levels were similar between these three age groups. However, lately, the under 20 have exceeded the 40 and 50-year-old daily counts. We asked questions about the supply and the appropriateness of the type of personal protective equipment from hand sanitizer on. And you can see that for eye protection and goggles and for N95 masks, there were a lot of people who indicated they needed them but were not available. And when we added all the PPE ratings together, 28% felt that 100% of their needs for personal protective equipment were met, whereas 18% had less than half of their needs being met. For infection control procedures, it was a different picture. It was a much lower rate of appropriate and adequately implemented controls. And only 4% felt that 100% of their infection control practices were met, whereas over 2/3 felt that less than half of their needs were met. We asked about ratings of support, whether these parties, the union, the employer, the government, or health and safety representatives, were doing their best to protect the respondents and others at work. And the union had the highest rating of over 50%. The employer had about 1/3. The government had a very low level, 6%, and health and safety reps were a bit higher than the employer. When you compare these to the other surveys we did, the educational workers are in teal, light green color here. You can see, especially for the government, that they were quite different. And that's probably somewhat due to the fact that they were in negotiations just before the pandemic started, and it really caused a lot of problems. Healthcare workers, the union was similar to on-site essential workers and fairly similar to education workers. The employers were a bit higher, and government was higher for healthcare. For the non-healthcare, those who were working remotely had the most positive ratings for these parties' performance, whereas essential workers who were working on-site had much lower. When we split up the in-person and online, we saw that the people online had less overall rating of the support received from unions, employers, and health and safety reps. When we asked about exercising your right to refuse dangerous and unsafe work, people were more inclined to exercise that right if they had inadequate personal protective equipment than if there was inadequate infection control practices. Then we asked, how would you rate the psychological health and safety climate in your workplace, ranging from healthy and supportive, good, fair, neutral, not so good, poor, or toxic? And here you can see the levels of the respondents, and comparing them to the Canadian average, you can see there are a lot more negative results than the pre-pandemic survey that we did for Canadian workers. And the COPSUC psychosocial factors, again, comparing them to a survey that was done in 2019 before the pandemic, you can see that pretty well all of the factors measured were much worse than previous to the pandemic, except for colleague support. Supervisor support was about the same. And when we compared online and in-person, most of the online levels were at least 5 points higher than the in-person levels. And a 5-point difference is something that is considered clinically, quote unquote, significant. And now Peter will share some of the statistical analysis in more details.
Thanks a lot, John. Here's the scientific co-director of the Institute for Work and Health and a longtime partner in helping us actually find meaning in the surveys that we offer in trying to help workplaces find solutions. So thanks very much for your past, present, and future work, Peter, and we look forward to hearing your analysis.
No problem. Thank you, Val, and thanks everyone for attending today. So as John said, I'm going to discuss some information about both about the educator survey and also compare that with the 2 other surveys that we've completed, focusing on protective equipment and infection control practices at workplaces and mental health symptoms. Just to acknowledge, as John has done as well, the members of the ad hoc pandemic survey group, in particular, Dorothy Wigmore and Laura Lazansky and Alec Farquhar, who gave us a lot of feedback on the different questions. Tracy Edwards and Kimiko Ione at the Elementary Teachers Federation of Ontario, and also the other authors on some of the manuscripts, Guy Potter at Duke, Cam Mustard at the Institute for Work and Health, and Leonor Cedillo. And just lastly, with John and OHCOW, none of this work could have been done without John and John pushing away at it and OHCOW supporting him to do that. And so we really do owe a debt of gratitude both to John and to OHCOW for allowing us to understand the experiences of workers during this time period. So in terms of the work that I'll be presenting today, it's about exploring the relationships between the perceived adequacy of personal protective equipment and workplace-based infection control practices and anxiety symptoms. In 2 of the papers, we also focus on symptoms of depression, but I'm going to focus on anxiety because that is certainly the condition that I think is top of mind and most influenced by inadequacy in both these contexts. Oops, I don't know what just happened there. My computer got a little bit edgy. So in terms of the study samples, there's a healthcare worker survey which was conducted between April 7th and May 13th. 2020, of which there's just under 6,000 respondents in the sample that we'll be analysing today, or I'll be presenting today. There's a non-healthcare worker survey, which was people who weren't in healthcare, which was conducted between April 26th and June 6th. And of that, there's just under 4,000 people that I'll be presenting on today. That survey did cover, there was about 1/3 of the sample which were in the education sector in terms of that survey, but I'm not going to tease them out for today's presentation. And then there's elementary teachers and education workers in Ontario, which was conducted at the end of last year between November 23rd and December 21st. And then there's, for that particular survey, although John's presented information both on people who are working remotely and people who are teaching online and people who are teaching face-to-face, I'm going to focus on only those who are at the school work site for the whole week, which is just under 5,000 respondents. So all the surveys are web-based surveys. The survey links for the first two were distributed via various labour organisations. For the elementary teachers survey, they were distributed through EDFO. It's a convenience-based sample, so it precludes estimating response rates. But at each time, or for each survey, we have compared the sample which we've recruited to those, I guess, the general source population from which we're trying to recruit from. In terms of the healthcare sample, there were slightly more older workers, more female, longer job tenure, fewer part-time workers, and we had a very low participation rate in Quebec for that particular survey. Although it was a very large survey, it was almost 8% of the entire healthcare workforce. For the non-healthcare worker survey, we did have an over representation of people in the education sector compared to other other industries at that time, slightly older and more female, which is typical of all surveys where you get younger men just don't like to respond to surveys. In terms of the EDFO survey, the teachers and education workers, we compared that to the EDFO database. And we did, again, we have fewer men, fewer younger workers than in the EDFO database, and slightly more experienced workers and fewer part-time workers. So in each of the different surveys, it tends to be an older, more experienced sample, more female sample, more full-time sample. Just to put the surveys in perspective around the COVID case counts in Canada, you can see at the very left of this screen is the healthcare worker survey, which is the blue bars. That's slightly overlapped with the non-healthcare worker surveys, both conducted at the peak of the first wave of the pandemic. And then you can see that the EDFO survey, which is the red bars on the very right-hand side, is a very different situation in terms of case counts in Canada at that time point. This is edging up towards the peak of the second wave. And as we've seen since then, we've had a reduction and then a third wave, which we're just sort of at the top of, hopefully, at the moment. In terms of anxiety symptoms, so these are, in the first two surveys, we assessed these with a screener, which is the GAD-2, the General Anxiety Disorder Questionnaire, with 2 items, which asked about feeling nervous and anxious or on edge and not being able to stop or control worrying in the past 7 days. And that's scored on 4 different levels. So you can report out not at all for several days, for more than half the days, and nearly every day. And that, as a screening tool, is scores of 3 and above for those 2 questions suggest that you should seek further healthcare consultation around potential anxiety disorder. For the educator sample, we're able to use the GAD-7, which is a more robust instrument in terms of assessing the prevalence of anxiety. So it has the 2 previous questions, plus it has 5 additional questions about worrying too much, about trouble relaxing, being restless, becoming easily annoyed and feeling afraid. And because we have the 7 questions, we can actually divide people into 4 different levels of minimal anxiety symptoms, mild anxiety symptoms, moderate anxiety symptoms, or severe anxiety symptoms. It has been suggested that you could potentially group the moderate and severe, which would be similar to the 3 and above criteria for the GAD-2. But this is a more detailed assessment of symptoms of anxiety. In terms of the perceived adequacy of personal protective equipment and infection control practices, in each of the different surveys, we've grouped these into four buckets. So where people have 100% of their needs met, where they have more than half, but not 100, so 50 to 99%, where they have less than half, so 1 to 49%, and where they have none of their needs which are being met. In the non-healthcare sample, we also had people who were working remotely, which we could compare anxiety symptoms, and people who had lost their jobs, which was a very small proportion of the sample, but we were able to compare anxiety symptoms among those 2 people who are still at the workplace. Just to give you a description, so we did change the items which were assessed in each of the different surveys. All of the surveys asked about gloves, eye protection, face shields, gowns, hand sanitizer. All asked about surgical masks and N95 masks. And you can see for soap and running water, We asked that in the non-healthcare survey and in the educator survey. For regular half full-face cartridge respirators, we asked that in the non-healthcare survey, and for powered air particulate respirators, we asked that in the first two surveys. For each survey, we used the same response categories. We asked people if the type of personal protective equipment was there. So for people who said they weren't sure or they didn't know if it was appropriate, or people who said it wasn't applicable, we said that type of personal protective equipment wasn't needed. And then among those who said it was needed, for those who said they had the appropriate type with adequate supply, we said the need was being met. And the other groups were the appropriate type but inadequate supply, an inappropriate type but adequate supply, an inappropriate type with inadequate supply, and it was needed but not available. In terms of infection control practices, there's a variety of different types which we asked about. So these include things like ventilation, the installation of physical barriers, things about physical distancing, both from co-workers and from clients and students, screening procedures, staggered schedules, cohorting, and then other different aspects around cleaning, waste disposal practices, laundry facilities, procedures around face masks. And you can see that there was a different variety which we sort of tailored to the needs in consultation with the pandemic survey workers group and also with EDFO for the educator survey around the types that were most appropriate to ask about in each of those different surveys. And again, we looked at where the need was met, which the need was where the infection control practice was needed, but also where that need was being met in the same ways where people said, well, they had the appropriate, it was appropriate and adequately implemented. We said the need was being met compared to where they said that was what they needed, but it was inadequately implemented, where it was inappropriate, where it was lacking, that need was not being met. In terms of the distribution of the anxiety scores, so this is for the healthcare sample and the non-healthcare sample. This is using the GAD2, the screening instrument. Here I've put in the bracket for people who are scoring 3 and above. You can see 55% of the healthcare sample were screening at 3 and above, which suggests that they should seek further assessment for symptoms of anxiety or anxiety disorder. 42% of the non-healthcare worker sample. This is at the start of the pandemic. In terms of the Ontario educator sample, you can see now we can break it apart into these 4 different buckets, and you can see that 57% of the educator sample have either moderate or severe symptoms of anxiety. These are people who are working on site in November and December of last year. In terms of the personal protective equipment, John has presented some of this information already, but you can see there are different distributions in terms of the healthcare sample, the non-healthcare sample, and the educator sample. In terms of personal protective equipment, we can see that the educator sample was actually doing fairly well with a fairly low proportions, about 18% having less than half their needs met. Still, we'd ideally like that to be 0, but most people in the educator sample suggesting they had more than half of those PPE needs which were being met, which was a slightly different picture to what we had seen at the start of the pandemic among healthcare and non-healthcare workers. The infection control practices presents a different story. And so you can see among the educators, we had the 67%, which John had presented before, where less than half the infection control practice needs were being met among the educators, which is much higher than we had seen before among the healthcare workers and the non-healthcare workers in terms of the proportion of infection control practices that were being met at the workplace. In terms of the model covariates, so I'm going to be presenting some adjusted percentages. I'm not going to go through this list, but what we're trying to do here is adjust for factors that might be associated with the adequacy of personal protective equipment or the adequacy of infection control practices, and things that might also be associated with symptoms of anxiety, but are not in the causal pathway. Needless to say, just by the size, the number of words on this slide, there's a lot of things we adjusted for. And what we're trying to do there is isolate what is the relationship between infection control practices or PPE adequacy and anxiety symptoms. And I think we're fairly confident we've adjusted for most of the important factors that might present a spurious relationship between each of these, between our exposures and each of our outcomes. These are the scores for the healthcare worker survey around personal protective equipment and infection control practices. And you can see there is this graded relationship that we had witnessed around People which had all their needs being met had the lowest symptoms of anxiety. People who had none of their needs being met had the highest symptoms of anxiety. But we do see this steep graded relationship where for every increment of lower adequacy around personal protective equipment, we have higher symptoms of anxiety among the healthcare workers, and differences of about 18%, which at that point, that's an absolute difference of 18%. So 18 in every 100 workers where needs aren't being met have anxiety compared to where they are being met. We thought that was quite a startling difference at that particular point at the early part of the pandemic. In terms of the non-healthcare worker survey, which was again done at the start of the pandemic, we did see lower anxiety symptoms among those who were working remotely compared to those that were site-based or who had lost their jobs. But when we again separated it by infection control practices, we actually saw that those people who were at work where 100% of their infection control practices were being met had slightly lower symptoms of anxiety than those who were working remotely, slightly, not statistically different, slightly lower. So this is PPE. And those that were at the workplace which had none of their PPE needs being met actually had higher symptoms of anxiety compared to those that were not working. And this is for the educators. So I told you that we thought the differences among healthcare workers were quite startling, but these are the adjusted proportions of moderate and severe anxiety among the healthcare workers across PPE needs and infection control needs. So these are PPE, which is on the left, infection control here, which is on the right. Because the PPE needs in terms of those lower groups were quite small, we've grouped those at the bottom end. So we don't have a group where 0% of the PPE needs to be met. They're grouped along with the people who had less than half. But again, you can see these very clear graded relationships between, for PPE needs, 44% of those people, 44% of the people with 100% of their PPE needs being met had symptoms, moderate or severe symptoms of anxiety, compared to 70%, which had less than half of their needs being met. And for infection control practices, again, you can see an even steeper relationship. For that 4% of the sample, which had all their infection control practice needs being met, only 24% of that group had moderate or severe anxiety, compared to 70% among people with 0% of their needs being met. So there's, I think, two important messages in this particular graph is both, this is what happens when we can't provide adequate infection control practices for these workers. And if you look at the bottom, this is what happens when you can. So really important differences among being able to provide infection control practices and not being able to provide infection control practices, and symptoms of anxiety among educators in Ontario who are working on site. So just to briefly talk about the strengths and limitations. So the representativeness is always a question mark in terms of convenience-based samples, but in terms of trying to understand what's happening at the time, I would trade off representativeness for understanding what's happening at the time 9 times out of 10, because it is important to understand the situation as it's evolving. As John said, it's very hard to recall what's happening a year ago, or 3 months ago, given the rapidly evolving situation that COVID has presented. Given the dynamic nature of COVID-19, obviously these experiences only represent what was happening at the time. That's one of the challenges around comparing our healthcare worker survey to the non-healthcare worker survey to the educator survey. Very different time periods in terms of COVID burden among Ontario. The exposure is based on the perceptions of need, but we did, in each of the different surveys, we looked at if we added in the number of needs that someone said they had, did it change the results, and it didn't. And perceptions are really important to address, as we've seen that, there's, at the start of the pandemic, there was a lot of things about, well, we don't really need to worry about airborne infection control. And now we've seen that actually we do need to worry about airborne spread of COVID. And so the perceptions that people want to feel safe when they go to work. And so enabling people to feel safe, I think, is an important thing that we want to address. And that's based on their perceptions. So key messages, high rates of anxiety, 55% of our healthcare sample and 42% of the non-healthcare worker survey samples at the start of the pandemic were screening for anxiety disorder. 57% of our educator worker sample had moderate or severe symptoms of anxiety in November and December last year. These clear graded relationships show that as an intervention to help reduce anxiety symptoms, PPE adequacy and infection control practices are important interventions that we need to focus on, given the clear graded relationships. Obviously, the purpose of providing PPE and infection control practices is about protecting workers from COVID, but not adequately doing it increases the risk, not only increases the risk of COVID, but increases the risk of anxiety symptoms, as we've seen both in healthcare workers, non-healthcare workers, and educators. So providing and effectively implementing infection control practices results in much lower symptoms of anxiety, which I think for those people who are continuing to work on site is something which is really important for us to make sure is being done. We do need to continually monitor employer-based infection control practices in all workplaces. And in terms of ongoing and monitoring the mental health of workers, we need to do that, especially for workers who are continuing to work on site. And we don't need to do it, we don't need to stop it once we see case counts drop, but understanding the long-term ramifications of these elevated symptoms of anxiety is important going forward, not just for the next year, but for the next number of years, I would say. In terms of more information, both the healthcare worker survey and the non-healthcare worker surveys have been published now. They're both open access publications. The healthcare workers in the Canadian Journal of Psychiatry, the non-healthcare is in the Annals of Work Exposure and Health. The educator survey has been submitted for publication. There's also a piece in The Conversation which we wrote about the relationship between PPE and anxiety and depression. People are free to access. If people want to chat with me now, I guess or after, I'm here. But if people also want to email me, they can as well. So thank you again for your attention.
Thank you very much, Peter. I think we will save the questions till afterwards, although you Sal did ask a question about the date of this data. I guess as far as he understands, these figures are from the very beginning of the pandemic, but I guess so maybe you want to clarify that the cohorts are at different times, and do we have follow-up data and have things changed or evolved? So
they are. So the healthcare worker and the non-healthcare worker sample were at the peak of the first wave, which is around April, May last year. The educator survey is from November and December last year, which is where we're edging towards the peak of the second wave. So the different time points. In terms of follow-up, we did include an option. John probably knows the numbers better. I do think at the particular time that we tried to implement the healthcare worker survey, to be honest, healthcare workers were sick of doing surveys. They actually wanted PPE and infection control practices much more than they wanted to participate in another survey. So participation rates are a little bit lower, but I do think there are opportunities going forward.
Great, thanks. And yes, I guess, well, John, maybe we can talk more later. The survey is still open, but we haven't done any campaigns around it or anything like that. So I guess, and John has answered that he's just analyzing the results of the second wave surveys. So now we're going to switch to our third speaker, who's Leonor Cedillo. And she is discussing the qualitative analysis of the recent surveys. Sorry, I don't have it. And important insights from qualitative analysis of the pandemic experience survey comments. And Leonor has been working with us since December and working on our workplace mental health efforts, including this survey analysis, as well as on our migrant farm worker program, and has added a lot of dimension to our work, and we really appreciate it. So,
good morning, everyone. I am Leonor Cedillo. I am a researcher on occupational health and safety and the psychosocial environment. I am collaborating with OHCOW in these very interesting projects with John, Peter, and other colleagues from OHCOW. I will present you some of the insights from the qualitative analysis of comments in two of the pandemic exposure surveys. What purpose do comments serve? Giving voice to participants, among other purposes that you can read on the left side of the slide. Many authors have discussed the function of open-ended questions in surveys, particularly those asking for further comments. Opinions about their value and limitations have been addressed as well. Since the mid-1930s, Lazarsfeld was reflecting on the art of asking why. Here are some references. Some researchers consider that responses to open-ended questions are qualitative data. Some others have labeled them quasi-qualitative data. Open question comments could be made representative with the use of mixed methods and random samples. In any case, it is necessary to have a strategy for their analysis. In the case of the pandemic experience surveys, placing questions for the respondents to add further comments at the end of the survey was intended to gather detail on any of the situations involved in the survey. It also envisioned us bringing to light aspects that were not addressed in the survey, and, very importantly, to communicate the vivid experience of the respondents, and through that, draw attention to those that are most significant for respondents. However, there is no way to quantify these qualitative results, and each response may be representative of a smaller or larger group among those surveyed. In this way, they may also represent an area of concern of greater or lesser generality, but they can also have important implications. What did we get from the EFTOS survey? The request for further comments was placed at the end of the survey, inviting the respondents to provide their reflections on all the topics addressed in the survey. 26% of the survey respondents contributed comments, 88% of whom were women and 12% men, compared to an overall gender composition of the survey respondents of 91% women and 9% men. The comments add up to more than 85,000 words. That's the size of a book, but one that has not order in its paragraphs. So that is the task for the analysis, to find the story or stories behind the jumble of paragraphs. I will share with you some of the respondents' experiences. Here is what a teacher says. He has more than 10 years of experience. He is exhausted, he is committed to his job, but reports insufficient resources to do it. Other education workers considered us to the high work demands and insufficient support with resources. One of them, who is working long hours, highlighted the number of students she teaches and the particular needs that special education students have, for which there is no support. The other one is concerned about the introduction of a new math curriculum and the lack of training, on top of following the COVID protocols. Workers also questioned the policy decisions taken at the different levels. Are those decisions supported by science? They also have something to say on how to teach and care during a pandemic. Comments were very rich in content and were captured under various categories. The final report for EFTO was based on more than 1,100 text references, classified into topics and subtopics that were grouped into 10 broader themes that you can read from the right of the slide. Here is an example of the first page of the report, summarizing just one of the 13 aspects described under the theme of work organization. This is just for you to get a glance at how the issues are interrelated. Some demands are clearly related to COVID, while others are demands that reflect issues that would be normal in pre-COVID times, but that add to the current already increased workload. Here is an example of the second section of the report, summarizing 2 out of the 12 aspects described under the theme of COVID concerns. Although there are a variety of concerns, we can say that they basically relate to 2 spheres, health and work. Concerns about health include those related to COVID, as well as burnout and mental health issues among workers, as well as concerns about the students' physical and mental health. We just saw that concerns about work are related to work organization, but professional concerns are also very high in this population, linked to work performance. Professional concerns and work performance relate highly to consideration for students' needs. Both areas, health and work, have students' needs as an important component. Concerns about profession were expressed by the respondents. Feelings of failure and betraying their professional responsibilities made some teachers think about leaving their profession or taking early retirement. In this survey, what we can get from the qualitative analysis of comments is what they add to what we learned from the quantitative survey, and the greater detail they add. Examples of additional information we got from their comments can be read on the left side of the slide. Aspects of the survey that provide more detailed information are on the right side. As I said before, we got more detail on certain situations. For example, the main aspects referred by the respondents in working remotely as opposed to those working in school. The data shown here could help us in clarifying the aspect of representativeness. According to some authors, the representativeness of comments in a sample of a survey respondents depends on comparison with every variable on the overall sample. We also got results from a pandemic survey among healthcare workers. In this case, we asked for further comments and also for suggestions and ideas that might help respondents to do their job more effectively. 21% of the survey respondents provided comments from more than 4 different types of healthcare facilities in 8 provinces who are members from various unions and associations. In total, the comments add up to 7,087 words. In this case, mixed methods were used to get more specific information, but not to compare between groups. 149 respondents were from Ontario, followed by 34 from British Columbia. The other provinces account for a total of 15 more. 82 work at a hospital, followed by 59 working in an outpatient clinic and 13 in long-term care. 52 more worked in another type of facility. 40% of the comments were ideas for improvements, having to do more with the staff and more resources to do the job, better and more complete information about the continuous changes, better communication between managers and staff, and with the Health and Safety Committee, as well as better ways to separate patients with symptoms. Here are examples of the comments from workers in outpatient clinics in Ontario. On the left is an example of the coding process conducted for each of the comments. Both workers talk about the oversight in their work. In one case, an external audit that contributed to generating stress but not to doing the job better. The other worker wishes that her supervisor could be more familiar with the nature of the job. It is clear that workers know their work and responsibilities and how to improve them. However, they do not have control over their schedules and are overworked. The main health and safety issues are the pandemic, infection prevention procedures, and organization of the work as part of the procedures. There were more than 30 comments regarding personal protective equipment. There was also a question in the survey regarding PPE restrictions, and respondents were asked to specify. Many answers about restrictions correspond to more than one type of PPE. Here you can see that masks, respirators, and goggles were the ones reported in the restrictions. Here are some challenges while asking for comments in surveys. It is important at what point in the survey respondents are asked to give comments, as well as how the question is put. We saw a difference in the comments of these two surveys. Education workers did have suggestions for improvement. However, not as many or as clearly defined as the healthcare workers, who were asked specifically about making suggestions. Once you get the answers, it becomes an ethical responsibility to analyze them, along with the main part of the survey. Another challenge is the consumption of time of the researcher or researchers involved, especially when they are more than one in order to increase reliability. Generally, actual quotes are required for publications, while protecting individual identities. However, the organizations involved in the study do not always feel comfortable with this. From what we learned about the comments from the respondents to these surveys, workers have something to say, but they like routes for participation in the decisions about their job and about health and safety. Many comments pointed to the need to improve communication in the different levels of decision making. Resources are required to meet the needs to do their jobs and preserve their health. Thanks for your attention, everyone.
Thanks a lot, Leonor, and John, too, I guess, for streaming the presentation. I was just reminded on your last slide of the regional risk tool that we put together last August and September, which we can put in the chat, although most people are aware of it, but that we made communication the very first thing in any COVID response plan. There's all these categories that are meant to be covered sort of, you know, technically, scientifically, administratively, and all that kind of thing, but communication is key. So that just resonated in the words that you described as well. So does anybody have any of the speakers have any comments that they have arisen even before we go to some of the comments and questions in the chat? Just any thoughts for the morning in the group?
What struck me was the similarity between the experiences of healthcare workers in Turkey and in Ontario or in Canada. But also it seems to be a little more severe in Turkey, especially financial issues and things like that.
Yes, I'm also surprised to hear those, but Yes, the financial issue is very important in Turkey. The Ministry of Health promised to have an increase in the salaries, but there is no increase. That's why the nurses, especially the nurses, are very. They are not happy about this issue. They are angry at the management also. That's why the main differences might be this.
Are they unionized there?
Yeah,
Yes, they are unionized, but they don't have the support of unions, or they can't perceive the support, maybe. That's why they ended their membership.
the problem was actually the Ministry of Health support the other healthcare workers, but not to the university staff, because university is not belongs to Ministry of Health. But on the other hand, they appointed university hospital, it was our hospital, appointed as a pandemic hospital, but when they deliver the money, they don't give this support to university hospital, but the other hospitals and the state hospitals. So this is kind of discrimination, and it make the nurses and other staff kind of, to discriminate it from the other groups. And of course, not all the staff know this, because they think that the management decide this. So there was a great discussions among the staff, because they think that the university decide not to support their staff, not Ministry of Health, because they know the other guys in the state hospitals earn, triple, 2 or 3 times more salaries during this pandemic, the first wave, especially in the first wave. So this made people so disappointed in the university workers, among the university workers.
And also, the biggest share was taken by the doctors.
Yes.
Not by the nurses, but nurses say that we are doing the whole work, not the doctors, but we couldn't get the what we deserve.
The problem was actually some of the people, maybe Burcu also said that some of the nurses said that we don't say that we want money for these services, but you said we will increase your salary, but you don't do this. So it is crazy, They offer this, but they don't. So it is kind of, and also the inequality, of course, the big problem, because when they give this additional money, it goes mostly to the seniors, the doctors, but nurses said that, of course, they spent a lot of more time with the patients, pandemic patients, than the doctors.
Mm-hmm.
Doctors just order and go their home, but nurses always spend longer time in the wards, in the pandemic wards, and with patients. They feed them. Still, they are doing this. Mm-hmm. So it is a big problem.
Yes, they also have a caring occupation. They have to care for the patients, support. And also the patients are in need of care here, especially in the COVID services. They are in need of nurses' care if they are not intubated, if they are spontaneous patients, then they need lots of care. And this is done by the nurses. Causes emotional exhaustion. Actually.
Yes, it's not moral outrage, moral injury, right? I think that it is, and I think it's massive in our time. I'm not sure that our pandemic experience survey really measured that. Did it?
I don't think so, but some of the comments did mention it.
There were a number of questions, some of which were answered, but in case there's people that weren't following, I guess there was a question about the prevalence of positivity, and John, you answered with respect to more cases. I guess we don't know the positivity measurements for healthcare workers, but we know the cases that are counted, I guess, which we're not sure those are all the cases.
There's data available, as I mentioned. However, it's not being communicated well and in a format that's easily digestible, as I myself confused at one time person days with actual people being indicated as having COVID, whereas the counts were actually the number of days people were. So, but anyway, it's been a challenge. I think Peter might have a few comments on the quality of the data and the way it's being communicated to.
I mean, there's a lot of data and a lot of people sort of grabbing different bits of data. I think some of the, as you said, John, there's often some of the data that's available is around just the number of people who they think currently are infected. So it's not a count of individuals who are infected. There is some available on the Ontario data portal, which different people can look at. But it's you've got to remember that that surveillance data is just surveillance data. Like it's from the people who go to get a test and the people who test positive. There's a lot of asymptomatic COVID cases. There's people who don't get tested because they can't afford the time to get tested, and so we just need to keep in mind that surveillance data is surveillance data. It's not a gold standard of everything that's happening. There was a comment from Dorothy about men and women and separating men and women, especially around the remote work.
Mm-hmm.
And in the non-healthcare worker paper, we did examine differences for men and for women and for older respondents and for younger respondents. So we didn't find any difference. But I do think there are particular challenges around remote work, and which are disproportionately borne by females around, especially females with school-age children and younger, around trying to work remotely and also take care of it now with schooling, with all the schooling in Ontario being remote. There's a huge number of challenges, and I think they are being disproportionately borne by female labour force participants. But in our particular survey, we didn't see that difference in the sample.
Thanks, Peter. And Dorothy did ask you, John, and maybe it's for everyone in terms of what's the most striking finding, and then I guess since the discussion is meant to turn to prevention, what are some strategies for prevention from that finding? We could even go in order. Burcu, do you have any comments around that in terms of what you found was most striking, but also then maybe the best opportunity to make a difference? Aside from the pay differential, because I can understand that would be massively stressful on so many levels for people with that level of differentiation.
For intervention, for example, what?
Yeah. So what?
Question is about suggestions for interventions.
Yes, based on what you found. Yeah.
I think social support is a very important resource here. And we should use this. I don't know how to use this because there's also there should be a distancing issue, and people really want to get into face to face, and they want to meet in person. Mm-hmm. But maybe online meetings, again, sharing the experiences and telling about the workplace problems and trying to find solutions to those problems might solution. And also when we were having interview with the nurses, I realized that the nurses who are under the who are the subordinates of good leaders, they were really appreciating the leaders' behaviors there. And also they want feedback. They want regular meetings, and they want to be informed. That's why such kind of meetings and peer meetings, and also leaders also should contribute to those meetings. This can be arranged, I guess. If we cannot end the difficulty of the demands, then we can increase the resources here. And this is social support, I guess.
Thank you. John, did you?
I'd like to say something,
Yeah, go ahead, Leonor.
Valerie, in regards of what we are discussing right now. So we've seen that workers, either healthcare workers and also workers in the education system, have a lot of ideas on how to do their work better and how to take care of their health and in the case of the education workers, in the students' health even. So I think that there is a lack of paths for communicating all these ideas, for participating, and that is very important because it is a resource that is not that the system is not taking advantage of, because there are different situations in different schools or different boards that could that are managed differently between the schools and between the boards, but people have their ideas on how to improve them. So I think that's important to take that into account, as also the support that Burcu is talking about. And another thing that I find is very important also in the case of the education workers is transparency. Because even if there are some procedures that are in place, sometimes people are not all the people are well informed about that. And so the transparency is also a key thing to think about. Thank you.
Yeah, you too. Thanks. John, did you want to add anything?
Yeah, as I wrote in the chat, probably the most striking thing was that the levels for educators of anxiety were higher than for healthcare workers. And also, especially when Peter showed the results of the effect of having your infection control practices needs met, and how what a striking difference that had for educators who had all of their needs met or none of their needs met. You know, I've been doing lots of surveys for a long time, and it's very seldom that you see such a dramatic difference, and that leads to the suggestion that just providing what's needed for infection control practices in schools can make a huge difference to the mental health of the workers. I don't know if Peter wants to add to that.
No, I think spot on, John. I mean, I think the idea of, you know, often these things are not, if engaging with workers can find solutions so that they can feel safe at work, I think is so important. And I think in terms of the pandemic, if there's one lesson to be learned, is that too many workers have gone to the workplace feeling afraid. And I think that's an important thing that we should reflect on as to why that's happened and how we could do better the next time. Either healthcare workers, non-healthcare workers, and in this case, educators. And, you know, they're fairly specific things, so things around the inability to physically distance from other workers and from students. So, you know, these are things that we've known from the start of the pandemic that we needed to focus on, being able to keep people distance, you know, not in indoor spaces and with appropriate face coverings, screening procedures. So these were knowns, and it's just unfortunate that, you know, we had 2/3 of the sample reporting that they felt that less than half of those things were being met. So clearly communication about what's not being met and how it's not being met is important to do.
any of you have any sense of how the survey results have been used to maybe for more participative health and safety dialogue and planning in any of the sectors? Like in Turkey, have the results of this been used at all? Or John, do you know in the other sectors we've looked at?
Jude, do you want to
in
respond first?
Turkey.
Yeah,
In
well,
Turkey,
yeah,
are you asking that the authorities are aware of our results or not?
yes, and have they been used? Have they been presented to the workers and used in any way to dialogue about their health and safety and their mental health and injury prevention?
As the authority, I guess the management, the hospital management is aware of the results now, especially the nurses, the head of the nurses. So we will have the opportunity to make an intervention on this. But for the Ministry of Health or for higher authorities, now our results are not available now. We should have a publication first.
Yeah, actually, in the institution level, yes, we have one meeting with the nurse management, and we just presented the result. Actually, we don't have only the nurses. We have, please correct me, Burcu, we have 55 people from different groups of workers. I mean, the doctors and other staff, cleaners, etc. But we only analyze at the first step among the nurses, because they are more participative, and also their management also kind of more participative. So we are planning to make several meetings with the nursing management group. Then just yesterday I talked with even Burcu don't know this, talked with the head of the hospital, and I said something about the psychosocial risk, and maybe we can share with them also some of the results. Because therefore I asked this question, maybe you miss it. The management or managers don't aware of anything. They think everything is going somehow, as it is, because they don't have any experience with this. They don't face with these problems. Some of them, of course, they aware of some of the problems, especially for the related with the salaries. They know this, of course, but the other problems related with the management and also the support issue, resources, and etc. They don't know this problem. So maybe it's a good idea to talk with the managers also, how they think that, if they think anything about the psychosocial risk among the health the workers. So maybe we can have some interviews in the following days with the manager point of view, management experiences on these issues.
Thanks, Yücel. John, did you have anything else to add?
Yeah, we worked with a network of unions, and we've been feeding back the information to them. We also published a couple papers on it. But overall, yeah, it's been, we also did many presentations. So we've been trying to get the word out, but whether it's had any impact, I'm not sure. I think with the educators, Tracy's online, so I'm not sure if she wants to step up and discuss how they're using it. But working with just a single union, it was much easier probably to have an impact than working with a network of people from all over Canada.
Tracy, do you have anything you can say today?
Yes, I can say that we have shared generally what the results have been with our members, and continually tell them that we recognize the concerns and have provided some supports to them. And then in our meetings with the government, we continually mention these things as well. There was another study done in the fall by the Canadian Teachers Federation, a bit more general in nature, and that data has been shared, but we're dealing with a government that really isn't listening right now. So it's a bit of a concern, but we'll continue to share the research papers as they come out.
I wondered about, like, at the Joint Health and Safety Committee level, like a little bit more granular level, if any of it had been translated that way, and that and what that could mean in terms of dialogue and in terms of joint problem solving at the school level. Do you think?
Yeah, we have shared the Canadian Teachers Federation research with our local leaders already, and encourage them to raise those issues locally as well. And then we're just in the process of sharing this information with the local leaders, and I assume a lot of them will definitely share this locally as well, because we might be able to get the human empathy from the supervisors. A lot of the supervisors in the schools and the school boards are feeling caught in the middle because the ministry and the government is not providing the necessary resources, and they're also feeling very anxious about the situation. So maybe we can get a little bit more done at the Joint Health and Safety Committee level.
Mm-hmm. Thanks. I see there was a comment by Melissa to say, curious if the data reports will be used by provincial ministries of health and education to inform policy directives for workplace physical and psychological safety employer requirements. That would
you're
be
best to answer that one.
Well, it's a good question. I guess I'm not sure we've conveyed it to the ministries either. But we would like to think so. We would like to think that it could and would have some influence.
There have been representatives from many ministries at many of our presentations, so I think
Yes.
they are aware of it. And I see some people amongst the participants that are from various ministries.
Mm-hmm.
It's but yeah, if you look at the history of what's happened from the first wave to the second wave to the third wave, I think society as a whole has a hard time learning the lessons from each wave and applying them. So
seems like it.
Yeah, I don't want to just blame the government. It seems like it's a human element that somehow were difficult to teach.
Thanks. Kevin, did you have a question? You have your hand up?
Actually haven't formally met Peter, but I'm a big fan of all of the work that you're doing with John. So it's good to meet you even over this way. So really, it kind of was an open-ended question, and I know this really has to do with perception and anxiety, and that's what we're talking about here. But I just would be interested to know from your position where you sit. Have we think about infection control practices? I'm just wondering if you've got any thoughts around the current adequacy of infection control practices.
So thanks, Kevin. So I think in terms of, based on the survey information, so based on the surveys we did of healthcare workers at the start of the pandemic, not healthcare workers, and most recent one on educators, the levels of adequacy I don't think are where we would like them to be. I think one of the challenges has been that there hasn't really been a lot of systematic data collection in Ontario or elsewhere about workers who are going to the workplace, how they feel about the level of PPE, the provisions of different infection control practices which are in place. I do think in terms of what we saw in the educator survey, where we have 2/3 of our sample reporting that less than half their needs have been met. I mean, and most of those needs are the ones that we knew would need to be addressed around the spacing of children in classrooms, the screening of students as they come into the workplace, the screening of visitors as they come into the workplace, the need for adequate masking of students and visitors in the workplace. I mean, these are things which didn't just arise in the second wave, but we knew about them since March. And so I think there has to be more consultation. As I said before, I guess no, I don't think anyone should have to go to work when they're feeling anxious or scared. And there needs to be more consultation about what are people feeling scared about. So it can either be addressed through factual evidence about that's not needed, or that can be addressed by actually providing that level of infection control practice. So, we talked about the precautionary principle where we should start with providing the highest levels of protection and then work our way back once we know they're not needed. And I don't think we've done that in any of the sectors that we've investigated here from the start of the pandemic.
Thank you. I'm just wondering also, is it also that there's a level of confusion out there? So if you look at Quebec, for example, there was a newspaper article, they were talking about air purifiers in schools, and the Quebec board refused to install them or recommend them, whereas the English board recommended them. But I think there was also private sections of the Quebec education system that put them in place as well. So I'm just, there's kind of confusion out there too that probably being added to the mix.
Look, I agree. I mean, John, I think it'd be much better to talk about hygiene around ventilation and stuff. But, I think just the messaging, right, around indoor activity, outdoor activity, what's allowed, what's not allowed. I think there's been confusion from the start around guidelines. But John, I don't know if you want to just quickly comment on around ventilation stuff, because I think that's more your area of expertise.
Oh, Kevin has heard all my views already. He knows them. But yeah, we've been arguing with the Public Health Agency of Canada and Public Health Ontario, starting in consultations last February already, about what the appropriate level of protection would be, especially for aerosol transmission, which we were convinced from previous pandemics had been an important part that had been overlooked. We'd also been talking about the precautionary principle as per the SARS Commission, and a lot of those things were falling on deaf ears until recently, when it's been a lot more recognized in the scientific press and in the public press.
So our time is up. I did have one last question, I guess, and then we'll talk about the coming weeks. And I want to make sure we say thank you to all of the speakers who took the time, not just the time to share with us today, but that's very helpful to distill the information into ways we can absorb it and then hopefully mobilize it. So some of my question around mobilizing is around the peer support issue that was maybe most visible in the Turkish data, maybe because we didn't ask those questions. So wondering again, I guess, should we be asking more, or how can we cultivate those social support networks between peers and in workplaces? And would that help with prevention, even if it's a coalition about aerosol transmission, which some of us belong to actually as a peer support group? So just
if I can jump in on that one, if you look at the our Copenhagen Psychosocial Questionnaire scales,
right.
The one scale that was positive compared to all the other ones was the social support one from colleagues. And so one thing we have seen is, as workers face all these fears and uncertainties, it appears that they have been drawing support from each other in the workplace. So yes, we didn't ask specifically, But I think also Leonor, in some of her analysis, had comments about the effect of fellow workers helping each other out.
Yes, I think that, yeah, I'd forgotten that blue line showing positive reinforcement. So it's just finding ways to acknowledge that. I just pasted in the chat the next 4 sessions. So starting next week, we're actually very pleased to be welcoming more people from around the world to present as well as host in our partnership with the OHCOW network, which is the Copenhagen Psychosocial Questionnaire group that is the base of the survey that we've been using in Ontario for many years, since 2012, and is now part of our Stress Assess product that's been around for a couple of years. We could put the Stress Assess link in too, Vani. But anyways, next week, the network is hosting a session on psychosocial hazard regulatory frameworks around the world, which I think is very important. We don't really have a regulatory framework here in Ontario, although chronic mental stress is recognized as compensable for those covered by workers' compensation. But the regulatory framework is limited unless it's around harassment and violence. So they'll be hosting next week, and we have speakers from 6 countries, I think. So I hope everyone can join us then. And then the next week is solutions from Ontario, and those will be very interesting. As I said in the chat earlier, it'll be CAMH and administrators as well as worker reps or advocates that have worked jointly there to accomplish a lot in the last few years around violence prevention and anti-racial efforts this year as well. So I encourage people to sign up for that one. And then the OHCOW network is back on the 21st to share intervention stories of what worked and what occasionally doesn't work, but what we can learn from that. And I think that's also important. And then the last one, we'll be trying to share some new resources OHCOW is working on in terms of a website, and also other partners from the healthywork.org in the US who we met last year. They're coming back to share their new survey. And we're also hoping to hear about the ISO 45003, for which the voting ends today, I believe. So we'll know shortly whether there is enough support to create that as an international standard for psychological health and safety management systems. So lots coming up. I hope everyone can join us. And again, I thank all of the speakers today, Burcu, John, Peter, Leonor, and also Uchel for facilitating for us. And thanks again, everybody.